In 2024, the United States performed over 6.1 million aesthetic procedures, maintaining its position as the most active plastic surgery market in the world. The American Society of Plastic Surgeons reported steady growth across the board. Cosmetic surgeries increased by 1%, reconstructive procedures grew by 2%, and minimally invasive treatments climbed 3% year over year. But inside these growing practices, there is an operational reality that practice managers rarely discuss in public. The operating room is highly efficient. The front office is quietly struggling to keep up. This 40-hour medical workweek diagram shows 15 to 25 hours swallowed by scheduling, documentation, and authorizations. Extending the timeline, this burden spills into evening pajama time, a primary reason over 43% of physicians report burnout. Compounding that exhaustion is a severe staffing problem. The Medical Group Management Association reported that front office support staff turnover reached a staggering 40% in a single year. 4 out of every 10 front desk employees leave. Surging procedural demand combined with a rotating, under-trained front desk results in dropped calls, scheduling errors, and revenue leakage. The clinical team ends up absorbing the excess paperwork. Finding trained healthcare administrative staff is structurally outpacing supply. Over half of medical practice leaders identify finding qualified candidates as their single biggest staffing challenge. This flowchart tracks the labor shortage penalty. Replacing an in-house medical assistant costs up to $12,000. Factoring rising wages and benefits, a local hire costs $60,800 annually. A Staffingly virtual assistant runs just $21,600, a 64% structural cost reduction. Migrating the administrative layer to a virtual model allows practices to protect their profit margins despite a high turnover local economy. High-performing practices stabilize their operations through a strategy called decoupling. They cleanly separate patient-facing clinical work from back-office administrative tasks. They use specialized virtual medical assistants. These are not call center generalists. They are trained healthcare professionals who log directly into the practice's existing electronic health record system. Once inside, these specialists absorb the complex workflows. They process reconstructive case prior authorizations, coordinate insurance requirements, and manage detailed post-op follow-up communication. This timeline maps the implementation. Within 48 to 72 hours, a practice transitions from initial setup to full operational status, directly integrating the virtual team. With the back-office bottleneck cleared, the in-house team is left to handle only high-trust, in-person patient care. Surgeon time is fully protected from administrative creep. Managing plastic surgery patient schedules off-site requires strict enterprise-grade compliance to eliminate security risks. This compliance dashboard displays the exact certifications securing the workflow. Every data interaction is covered by HIPAA, SOC 2 Type 2, ISO 27001, and HIT-RUST protocols. AI-powered tools run quietly in the background of these workflows. They prioritize incoming tasks by urgency and catch recurring documentation or scheduling errors before they disrupt the system. Practices also gain a redundancy model. Because the virtual workflow uses cross-trained teams, an individual assistant taking a sick day does not cause the entire front desk to collapse. Strict data compliance, continuous AI oversight, and built-in staff redundancy provide a level of operational stability that a small, localized front desk struggles to achieve. As patient volume in aesthetic and reconstructive markets continues to climb, expanding administrative capacity without bloating fixed overhead costs is a requirement for growth. Practice managers can verify this workflow with a 30-day, zero-risk pilot, allowing them to test the integration before making any long-term commitments.